Believe it will boom.
But some governors who agree they can't keep their states shuttered indefinitely are still whining and finding a way to attack the president capriciously in many cases. Just listen to this from New York Democrat Andrew Cuomo.
Don't pass the buck without passing the bucks. Don't ask the states to do this. It's up to the governors, up to the governors, up to the governors. Okay, is there any funding so I can do these things that you want us to do? No.
Well, President Trump making it clear today he's had enough of Cuomo's caustic partisan moaning. The president unloaded on him in a tweet. That tweet reads, quote, Governor Cuomo should spend more time doing and less time complaining. Get out there and get the job done. Stop talking. We built you thousands of hospital beds that you didn't need or use, gave large numbers of ventilators that you should have had, and helped you with testing that you should be doing. We have given New York far more money, help, and equipment than any other state by far. And these great men and women who did the job never hear you say thanks. Your numbers are not good. Less talk and more action. The president's private-public partnerships are beginning to pay off in the search for drugs and vaccines to fight the pandemic. New signs of more progress this evening. Scientists and doctors getting closer to a treatment and possibly a vaccine with which to fight the Wuhan virus. An experimental drug from Gilead called remdesivir showing promising signs in a Chicago clinical trial. Patients in that trial experienced rapid recoveries from fever and respiratory symptoms, and nearly all of the 113 patients in that trial with a severe case of the disease were discharged from the hospital in less than a week. Well, joining us tonight to take all of this up is Dr. Mehmet Oz. He is the host of the Dr. Oz Show, director of Columbia University's Integrative Medicine Center. Doctor, good to see you. And I must say, without too much emphasis on investors, but they seem to be, at least in terms of practicing medicine, they seem to be very convinced that this drug from Gilead is the real deal. Your thoughts?
Well, remdesivir is a medication that has been used and tried for other illnesses in the past. It's very effective against these RNA viruses because it gets into the cell and impersonates part of the RNA sequence. It gets in the way of the enzymes that reproduce the virus, and that stops the virus from growing. And these antivirals are very promising across the board. They haven't been shown in clinical trials to work for coronavirus yet, in part because we haven't had enough time to do the research, but it's encouraging that this early information out of the Chicago clinic, based on a few different centers, has revealed that in the sickest of the sick, it's resulting in patients being able to get past their fevers and, in many cases, go home. I'm going to caution everyone, though. It's not a randomized trial. When they report out the results eventually, it will not be a randomized trial. So it's just going to be a case series. Valuable and interesting to follow, but it doesn't mean that it works as well as we think it has to work in order to get past all the muster that doctors usually have.
The excitement among investors over these antivirals, and I have to, in companies that produce them, and I should disclose that I own a number of the stocks, none of them purchased before the public's knowledge of these, their potentialities or other investor enthusiasms, just to be very clear. I think these antivirals are really taking on a lot of attention. The prospect of vaccines, there seems to be more of a balanced view on that, understanding that it's going to take a while. I say a balanced view among investors. What is your judgment on the prospect for a vaccine? Has it improved much since we last talked?
I believe the vaccine technology is advancing very rapidly, not just in this country, but around the world. There's some clever ideas that are based on concepts that are already in development, which has saved a lot of time in the development of these vaccines. Instead of years, with the ingenuity of inventors around the world, we're going to have vaccines, I believe, in a year, but it's going to take that long, which means these other drugs like remdesivir, which is an antiviral, and that family of medications could ideally play a role in keeping people healthy Especially folks with chronic ailments who represent 90% of the hospitalized patients, be able to get them through their illness without more consequences. There are also medications that block the overly aggressive inflammatory response. The cytokine cascade that happens when people overreact to the virus and by mistake start hurting their own cells. All these are different targets that medical science is pursuing. Again, they're all cutting edge because the virus is brand new. But I'm encouraged by the early data, and hopefully over time we'll find a few that work effectively enough that we'll trust them.
And your reaction to the 3 phases that the CDC has put forward for a return to normalcy in slow and safe steps?
I got to say, I think most folks who have studied public health agree these are wise paths to take. They offer a little bit of flexibility for different geographic reasons, but they're basically 3 things. There's the public health measures, which is testing and tracing using technology ideally. There's health system issues. Do you have enough capacity of beds in case you miscalculate? Will you have enough ventilators and the kinds of issues we struggle with in New York? Do you have enough protective equipment so you can have masks and hats and gloves or whatever else required? And then there's the individual responsibility that everyone who can hear my voice right now has to own, right? Social distancing. For me, social distancing is if you're less than 6 feet away for more than 10 minutes, you're not socially distancing. So develop some equations in your own mind and start to adopt them. You already are probably, but be especially strict if your part of the country opens. There's personal hygiene. And here's a really important thing. There's a gating criteria, which means that between each of these phases, there's going to be about 14 days of just continually watching how many cases come in. And if those cases are decreasing, that means you're doing well, that everyone's successful in their efforts. And theoretically, an area could move through, therefore, in 3 phases, so 1.5 months to go from phase 1 to phase 3. The last big takeaway is really critical. The life for people who are vulnerable. These are people who have chronic illnesses and comorbidities, hypertension, diabetes, bad lung disease. These folks, you don't want them out in the public in the early phases because I don't want them getting sick because the management of these patients is much more complicated when they get ill.
Well, Doctor, as always, we appreciate you being with us, and thank you so much. Stay safe. Dr. Mehmet Oz, thank you. Up next, the FBI's Christopher Wray is under some considerable pressure now from 2 Republican senators. They are urging him to provide answers about the FBI's politically corrupt investigation of President Trump. Investigative journalist John Solomon joins us here tonight with much more. Also tonight, Communist China has sought to dominate the world and America's military, America's economy and intelligence for years. How close are they? We take up their thirst for power and how it helped them cover up the spread of the deadly Wuhan virus. General Jack Keane joins us here next. We'll be right back.
We're working on today that would be like a screening test, because if you're positive on it, it's a good test, but it may miss that you actually have the flu. So then you would move into what we call the nucleic acid test. So we're trying to build an algorithm of tests that bring the full talent of the science of the United States into the reality of the clinic. And so bench to clinic. And so this is what we're working on for the future. Next slide. So as I promised both the senators and the governors, this is the United States' current platform capacity. Designated as high and low throughput. And what do I mean by that? We've talked about the high throughput platforms of Roche and Abbott and others. And then we've talked about the Gene Expert and other machines that may be moderate to lower throughput. I want you to see how it's distributed through the United States. So these are the current testing platforms available today throughout the United States for COVID-19. And as you heard from Dr. Fauci, everything has to be working from the swab to the transport media to the laboratory to really get those tests run and the results back to the client. The next slide. So then we've looked at all of the testing capacity from those platforms, and this gives you an idea of what that capacity is. The darkest red that you can see, like in Texas and New York, those are states that have lots of different platforms, as you saw on the prior slide, and the ability, if you just add up the platforms and the potential for tests, of over 1 million tests per month. And so this is what we're working with each of those states on unlocking that full potential. And how are we doing that? Well, we're calling on the American Society of Microbiologists. They work closely with 300 lab directors around the country. We talked with them this morning, and the Walter Reed team, who developed the entire HIV testing program for the military 35 years ago, have called them back into service, and they're calling lab by lab to find out what are the technical difficulties to bring up all the platforms that exist in your lab. Is it swabs? Is it transport media? Is it extraction? And I just really want to thank them. They've already worked through over 70 plus of those laboratories to really understand, and the American Society of Microbiologists and the academic societies of the laboratories are working together to ensure that all of this potential can be unlocked. Next slide, please. We talked a little bit yesterday about New Orleans, and the president talked about how many tests New Orleans has done during its outbreak, which you can see now is waning. They've done throughout the last month 27 tests per 1,000 New Orleans and Louisianians. So 27 per 1,000. So that is a good mark, and that's what Italy has done, about 20 per 1,000. So in evaluating an outbreak, and really to get control of this outbreak, they did about 27 tests per 1,000. So using that as a measure, next slide, we then looked across all the states of the United States of America and looked for states that had 30 or more, ability to do 30 or more tests per 1,000 of their inhabitants in each state. And you can see that across the country, except for Oregon and Maine and Montana. I worked overseas way too long. Thank you all. So those are the 3 states that we're working on building capacity in. So this is just to give you a perspective of how seriously we're taking the testing issue. As we've described, we've measured every single platform in every single state. We know exactly where they are by geography, by address, by zip code, what their capacity is, what their cumulative capacity is, what their roadblocks are on not ability to run all their full capacity. And we're addressing those because each one of those is different, and you have to address each of them one by one with the governors, with the state and local labs, and with all of the hospitals. I have not come across one laboratory or one laboratory director or one society that doesn't want to contribute to solving this issue of testing and ensuring that this testing is available for everyone. There is a strong, just as all the Americans have social distanced in behind everyone, we don't often talk about the laboratories, we'll talk about the nurses and doctors on the front line. Behind all of them are the laboratory technicians and laboratory directors who are coming in every day and putting things together to ensure that every single person that needs to be diagnosed is diagnosed. And hopefully you can see from these these slides, that really there is capacity out there. It is our job working with the states and having the state in the leadership role and the laboratory directors in the leadership role to provide support to ensure that all the potential for testing in the United States is brought to bear. I just want to end with, these are nucleic acid tests. There will never be the ability on a nucleic acid test to do 300 million tests a day or to test everybody before they go to work or to school. But there might be with the antigen test. And so that's why there's a role for nucleic acid tests, there's a role for antibody tests, and there's a role for the future development of these other key tests to bring the full ability to the United States. And so when we finish this, we'll be talking to all Americans, because there's other tests that other Americans should have. And I think this has really brought to light the importance of diagnosis. And we'll talk to you further about hepatitis C and TB and other things that we can do to ensure every American is healthy, because I think this has really raised the awareness among all Americans about how you do tests for different kinds and different parts of your disease state, and what is long-lasting immunity and what may be long-lasting immunity, and what is a nucleic acid test and what an antigen test is. And with that, Admiral Giroir.
Great. And let me amplify one point as the Admiral steps forward to include remarks about our approach and the efforts we put underway. Governors across the country have been working very closely with us to roll out the level of testing that we have today. And all the information we presented to you is going to be reviewed in the days ahead with all of our governors. Our objective is to connect every one of America's governors and state health officials to all of the labs that are currently able to do a coronavirus. But as Dr. Birx, Dr. Fauci both described, we believe today that we have the capacity in the United States to do a sufficient amount of testing for states to move into phase 1 at the time and manner that they deem to be appropriate. With that, I'll allow Admiral Giroir to complete our briefing on testing, and we expect the President to return.
Thank you, Mr. Vice President, and thank you to all my really great colleagues. Can I have my next slide? So I wanted to start by where we are today and just to visit where we've come in such a short period of time. As everyone on the stage has said before, our testing right now is well over 3.78 million tests that have been completed. And if you are impressed by bar graphs, that's over 1.2 million tests reported just in the last week. Ambassador Birx talked to me a little earlier, and she said, we only do about 2 million molecular tests a year for HIV, something that's been developed for 35 years. We're now doing twice that number of tests in a month for a disease that has never been known before, that there's never been a test developed before, and that's sort of where we are and where we've ramped up. I also want to give you a little idea. The lighter blue or lighter gray is our ID Now tests. So we talk about them a lot because they are a point of care test that can be between 5 and 15 minutes. And they have a very specific role, but they're not for everybody. If you've got to screen a few thousand people, 4 tests an hour doesn't get you there on a machine. You have to use some of the larger, higher throughput items. But they have a very important role. And again, coming into the market at 50,000 per day is really an important adjunct to us. She talked about the Gene Expert from Cepheid. Very important. We don't talk about that very much, but it is one of the backbone mobile point of care, not as easy to do per se as the Abbott, but it is a point of care test that really carries tuberculosis screening all through Africa. There are these machines, you saw that on her slide. Every one of the 50 states has this in over 600 sites, and they've done over 700,000 tests just on that relatively low throughput but very important platform. Next slide, please. I wanted to give you an idea sort of how the tests are distributed and how they're changing over time. On the left are the state public health laboratories. And although their numbers are relatively small, about 350,000, the state public health laboratories are absolutely critical. They're an absolutely critical core component of our testing. Not only were they there early and first, but they also do things like support outbreak investigations in nursing homes or investigations in certain plants that have a close proximity with everyone because of their work environments. They also do testing on many people who do not have the opportunity to be tested elsewhere, and they are performing outstandingly well. ACLA, I know we hate acronyms, but the American Clinical Laboratory Association. This is America's commercial industrial backbone that we're standing behind the president and the vice president. And when I was there a few weeks ago in the Rose Garden, this is the LabCorp, the Quest, the BioReference Laboratory, Mayo, Sonic, and ARUP. And you'll see they've done almost 2.3 million tests. This is the very large high throughput machines that Dr. Birx talks about. And I want to be clear about this group is that it doesn't matter where you are. I just took one of the largest labs and I said, map out for me where you are within 10 miles of where you are, every site in the country. And when you do that, within 10 miles of a site of one of these, 93% of the US population is covered. These are truly national reference labs that cover almost everybody within the United States. So if you cannot get a test at your hospital, the chances are overwhelming that you could send this to these labs that are fully caught up now. They have no backlog of tests. They've ramped up their production, so their turnaround time is about 48 hours because you may need to transport it from the middle of America out to a lab and result that. But that's really very, very, very good. The American Hospital Association, also academic labs, as the Vice President and the President have said, as more and more labs come online, they're increasing the amount of testing that are done just at the hospitals or at academic medical centers, now almost at 600,000 tests. And again, matching the other slide I had, the Abbott point of care test, just to give you a distribution. And that point of care test is being used very importantly in very select populations where a point of care test is really needed. That could be in some hospitals where someone needs to know exactly if a person is positive or not to go on a clinical trial or in a nursing home investigation, or sometimes to get people screened to go back into the work environment. Most people don't need a point of care test. In fact, a point of care test cannot replace the millions of
have authority over you. That is the basic social compacts there. And if this could break that compact, they're in real trouble.
General, we appreciate it. Good to have you with us. More than 30,000 Americans have been killed by this virus unleashed by the Chinese. The accounting will get much larger by the day. We thank you very much, General. General Jack Keane. New evidence of corruption and disregard for any kind of law and order by the FBI leadership itself under President Obama. During its politically corrupt investigation of the Trump campaign, it only got worse. John Solomon joins us here next. We're coming right back.
Over the past weeks, both the scientific community, the Gates Foundation, academic medical centers, the FDA have really opened up our ability to not stick that all the way back in your nasopharynx, but do the anterior nose, and to greatly broaden the amount of swab types that are available. So we are really at a point right now that by the end of April, we'll put another 5 million swabs in addition to everything that's out there now. And by the end of May, over 12 million new swabs in the system, more than enough to obtain the capacity that we need. Next slide. For these molecular tests, you take a swab and you stick it in a test tube. And that test tube has to have a specific kind of liquid in it. And when we started, it was viral transport media, a very special kind of media. The CDC has a make your own recipe. If you're interested in cooking, you could probably do that. But it has a lot of ingredients that go in there, but still very limiting. We've worked with many, many different laboratories. We've worked with the FDA. So now PBS, phosphate buffered saline, a kind of just laboratory grade salt water can be used for this. This greatly opens the ability to expand the test to support all the capability that Dr. Birx talks about. And again, by the end of April, we will have put well over 5 million new tubes of either viral transport media or saline into the system. I am going to get to a conclusion here, but this was going to be more of a technical briefing. Next slide. So let's talk about the fact that the science tells us that we have and will continue to have enough tests to safely go into phase 1. So let me be very granular about this. We've already heard that it is beyond the possibility to test everyone in this country every day. It's just not possible. But it's also a bad strategy, because testing a person now just means they're negative now. Dr. Fauci could be positive tomorrow because it's brewing in his system right now and we don't know it, or that he contacts that. That's not the way we go about things. The way we go about things, as Dr. Redfield said, just think of the weather radar. Okay, if the weather radar is clear, you're not going to have a thunderstorm or tornado. When something pops up, that's when you've got to go to where the action is, or know that your warning system is up. So sort of think of that in the background, and I'll go specifically about that. So that's monitoring. Let me talk about how much testing we need just for overall testing. I'm just going to give you a number. I'm not saying that this is the number that's there, but let's just take a number that we are going to enter phase one when there are 200,000 new cases per month in the United States. Don't get hung up on that. It's going to be much less than that, but let's just say 200,000 cases. So how many tests do we need? Well, we need to test those 200,000 people to make the diagnosis, right? Everybody nod your head about that. We have to do that. Now, what's a safe number over that? You know, if everybody I test has the disease, I'm not testing enough, right? But if I test 100 people to have one person with the disease, that's probably over testing. So we kind of assume that a safe number that really gives us a good idea is if about 1 out of 10 people are positive, then we know we're oversampling the population enough that we're getting all the positives. So if there's 200,000 cases, I need about 2 million tests, okay? Now, to go to Dr. Redfield's point, each one of those that are positive have contacts that need to be traced. And on average, the CDC tells me that for every positive, there are about 5 contacts that really need to be traced. So let's assume that those 200,000 people have 5 contacts. So now we have an extra million tests. So 2 million tests out there to detect the 200,000 cases, an extra million out there to trace those contacts. So we're up to about 3 million cases. If you want to put a fudge factor, say that's 4 million tests, okay? Those are generally done at the main hospital labs, the commercial labs, state and regional labs. All this can be done, as well as some of the labs talked about by Dr. Birx. Next slide. The second group of testing fits exactly perfectly with the influenza-like surveillance system that Dr. Redfield talked about. This is the monitoring. This is sort of the radar, the weather radar that it would be out there, that we're not testing people who are symptomatic. We want to do testing on people who are asymptomatic, because you can have asymptomatic carriage. You know, you could have this virus and shed it and not have symptoms or only mild symptoms. So what is the strategy here? The strategy here, this is an unprecedented strategy, okay? This is really unprecedented. But we're going to do between 300,000 and 500,000 tests per week in the most vulnerable populations that we know that the virus could circulate. And what are they? Number one, nursing home and long-term care facilities. We know that from the history of this virus that can circulate and be devastating, and it could circulate even in a way that you don't have symptoms. So we're going to survey in a very controlled way, driven by the CDC, supervised by the CDC. Surveys over, we may not get to everyone, but surveying in the areas to cover in a selective way the 15,000 or so nursing homes. Secondly, we want to work in vulnerable members in cities. And this is the way we think about that is community health centers. I'm a huge fan of community health centers that are led by HRSA. There are about 30,000 community health center sites. They take care of 30 million people, children, adults, elderly. They care for about 1/3 of Americans below the poverty level. They are arrayed to take care of our most vulnerable populations. So we want to survey asymptomatic people in those community health centers. We also want to do in some of our indigenous population, and you know very early I was out here bringing machines to the Indian Health Service, and in fact, 1,800 members of the Public Health Service provide care to the Indian Health Service, and their director and chief medical officer are both admirals in the Indian Health Service. Plus workplace monitoring, particularly for workplace environments that may have very close contact or may have a high risk, and some of those could be agricultural facilities. So let's just total that up. We have 200,000 people who need a diagnosis. To make that diagnosis, we want to test 2 million. Okay, so that's 2 million. We're going to contact trace with 1 million. And let's just throw you a fudge factor of about 25% on that, so that's 4 million. And we have this background testing of about 400,000 per month. So to safely do the testing, we need to be in the range of 4.5 million. You followed my numbers, because I want you to understand per month. That, pardon me? For phase one, right, for phase one. And I want to tell you, that's really how it adds up, and that's where we are. Right now, we're doing about 1 million to 1.2 million per week. We are going to continue to push that farther and further as we open up the laboratories and we're able to open all the supplies that we need for that. And I think that's where I would like to end. Thank you.
Thank you. I'll ask the team to step back up for questions, and we do anticipate, as his schedule permitted, that the president will be returning momentarily. Please.
You talked about phase one. Will there be enough testing for phase two? Do you have to ramp up capacity for that, or how do you deal with that?
That's a very good question.
Yeah, that's a great question. And what we will be doing is monitoring how much we have to use in phase one to really help inform phase two. Because the really unknown in this, to be completely transparent, is asymptomatic and asymptomatic spread. And so if we find that there's a lot of asymptomatic individuals that we find in this active monitoring and what we are very much concerned about, the most vulnerable, then we will have to have increased testing to cover all of those sites.
And as we've made clear to the governors and other health officials, we're going to continue to scale the testing. As the president's made clear, we want governors and states to manage the testing operations in their states. We've given criteria, we've given guidance for how we think that would best operate. But we're looking for the states, we're looking for the governors to manage it. But in the midst of that, all these great experts working with all these great facilities are going to continue to use that great American ingenuity to scale and increase the availability of testing for states to be able to implement as they move closer and closer to that day the president speaks of often, where we reopen America and put all of America back to work. Mr. President?
You did well. They all did well, I think. I'll bet they did. Please, go ahead.
Mr. President, thank you. Earlier today, Jay Inslee said that your tweets encouraging liberation. Jay Inslee said your tweets encouraging liberation in Michigan, Minnesota, Virginia were fomenting rebellion. Wondering how that squares with the sober and methodical guidance that you issued yesterday.
Well, I think we do have a sobering guidance, but I think some things are too tough. And if you look at some of the states you just mentioned, it's too tough, not only relative to this, but what they've done in Virginia with respect to the Second Amendment is just a horrible thing. They did a horrible thing, the governor. And he's a governor under a cloud to start off with. So when you see what he said about the Second Amendment, when you see what other states have done, no, I think I feel very comfortable. Go ahead.
Thank you, Mr. President. Just to be clear, when you talk about these states, Michigan, Minnesota, Virginia, do you think that they should lift their stay-at-home orders, or can you talk
No, but I think elements of